Bienvenidos. My name is Jacqueline Angel, and I'll be presiding over the session today entitled Caregivers and Cognitive Impairment in Mexico and the United States. We have 3 papers today that will be presented to all of us live, and then we will also have time for discussion and for questions. So with that said, we're going to go ahead and begin with the first paper by Dr. Sunshine ROTE on Mexican American caregiver health and turnover, the role of stressors, resources, and background factors. Dr. ROTE, are you able to get access to your slides?
I am. Thank you so much, Dr. Angel. Can everyone see my presentation?
Yes.
Great. So thanks so much for having me. So today I'm going to be discussing Mexican American caregiver turnover and depressive symptoms. And I just wanted to acknowledge my 2 co-authors and my mentors, Jackie Angel and Cocos Marquides, who are also on this paper. So to start, I just wanted to provide some background information on Mexican American caregivers and to provide some, information on motivations for our study. So in the United States, there are over 40 million people who are providing unpaid care to an older adult. And this can be very challenging. So the average amount of care provided per week is about 24 hours. And also caregivers tend to report that 26% of their income is used on caregiving related activities. And we know that with the growth of the older adult population, that the need for assistance and support will grow in the coming years, and more people will take on this caregiving role. We also know that the older population is becoming also more racially and ethnically diverse, and that informal or unpaid or family-based care is more prevalent for Mexican American families than for other groups. And this is due to really both cultural factors that emphasize the importance of family and family support, and also structural barriers and structural constraints that limit access to formal and paid caregiver supports. In terms of the research on caregiving, most of this research focuses on mental health and caregiver well-being. And so some of our research we've looked at is that Mexican American caregivers report really positive attitudes towards caregiving. So things that have been reported or, caregiving increases family unity, brings closeness with the older adults. So there's some really positive aspects reported by Mexican American caregivers. But on the flip side of that, there's also some evidence of high levels of depressive symptoms based on what type of sample you're looking at. And also definitely more demanding caregiving situations than other groups in the US. So we're really trying to understand what impacts long-term caregiver health and caregiver turnover. So there's very limited longitudinal research on caregiver health and caregiver turnover for Mexican American caregivers. And the reason why we're focusing on caregiver turnover is that there's one theory out there that when we're looking at caregiver health, it can get a little complicated in that there's idea that there's caregiver selection and that healthier people are more likely to select into the caregiving role and stay in the role over time. So really looking at this relationship longitudinally is important to understand who's dropping out of the caregiving role and who's remaining within it over time. So those are just some of the motivations for the study. So our research question is what caregiver background, stressors, and supports are related to caregiver turnover and depressive symptoms over 5 years for Mexican American caregivers. So we're looking really at this change over time to really hopefully inform intervention and prevention methods for Mexican American caregivers. So for this project, we're using data from the Hispanic EPIs, and the Hispanic EPIs is a representative data source of Mexican Americans age 65 and older living in the southwestern US. And it started in 1992, 1993, and followed up, older adults are followed up every 2 to 3 years. In 2010, 2011, older adults who were at that time 80 and older were asked information for the person they most rely on for help. And so these informants, or what we call caregivers, there were 925 were interviewed at the time. In 2016, older adults, again, and participating in the Hispanic IPs, were asked for the contact information for the person they rely on most for help. So this could be the same caregiver, this could be a new caregiver, and 460 were interviewed. The final analytic sample for the current study includes 344 caregivers that we have information on at baseline and follow-up. So to start off, I just want to describe the sample really quickly. In terms of looking at caregiver turnover between waves, we see that about 28% of the sample showed caregiver turnover, or there was a switch in the person from baseline to follow-up. So there was a new caregiver at the second round when they were the older adult was re-interviewed. And so in this study, we're looking at change in caregiver depressive symptoms. So when we limit the sample to the same caregivers, or caregivers from baseline to follow-up, there's 246. And so we're looking at change in depressive symptoms right here. And this is just a general change score. So we see in terms of the mean from baseline to follow-up, there was a mean increase of 1.74 on the CESD scale. In terms of caregiver background, we know most caregivers are in midlife, most are female, about 17% report receiving Medicaid, which is really an indicator of income and income stability. The vast majority completed the interview in Spanish. Most were adult children of the older adult. And about 6% were grandchildren of the older adult, which we think is pretty interesting. A lot of the other national caregiver studies, most of the caregivers are spouses. So here it's nice that we have good representation of both child, grandchildren, and then other types of caregivers. About half lived with the care recipient. So in terms of looking at stressors, what we're really interested in terms of looking at stressors is objective stressors and perceived stress. Objective stressors are just basically indicators of the older adult's functional and health status. So here we're looking at neuropsychiatric inventory or neuropsychiatric symptoms related to dementia. And these things include things like wandering, outbursts, anger. And this is just a scale of the severity of these different symptoms. And so our mean for this sample is 2.34. Hours of caregiving, we're looking at hours of ADL support each week, and this was about 3 hours. And then we are looking at the perceived stress score. There was a lot of variation in this, so we just tried to cut it off, right? We used a cutoff score. And so the top 30% here have high perceived stress in terms of the distribution. And then in terms of caregiver resources, we're looking at does the caregiver receive, help with the personal care of the older adult? And also, does the caregiver receive help outside of the family in terms of their caregiving supports? So in this first table here, we're just looking at caregiver turnover here. We find that gender was a significant factor. So you can see more men in the sample leave the caregiving role over the 5 years. So female is related to a lower odds. Also, grandchildren and other caregivers are also more likely to report caregiver turnover. And this other caregiver includes mostly other family, but also can include some possibly non-family caregivers as well. And so what do we think about these? I just want to break down the results by each type of finding we're having here. What we think here is likely this reflects the expectations and occurrence of timing of social roles. So Mexican-American grandchildren may have not expected to become caregivers for their grandparents, similar to like non-kin caregivers and other family caregivers besides spouses and children. And most of these grandchildren were actually in midlife at the time of the interview. So they may have been experiencing other competing demands with work and family responsibilities, and that might also result in some caregiver turnover. Similarly, we know with other groups, just like with Mexican-American caregivers, there's really, gendered expectations of who provides care in the family, with women typically assuming that caregiving role. And so that's what we think is accounting for some of this turnover over time. In terms of stressors, only NPI severity. So these were neuropsychiatric symptoms related to depression, to dementia. And so this really supports our qualitative work we've done with Mexican American family caregivers, where caregivers report that these NPI symptoms really create very challenging social and home life situations and conditions. And we find in our qualitative research that in interviews where Mexican American caregivers experience a lot of NPI severity, where the older adult has a lot of NPI severity, they report a really high need to stop caring or high levels of burnout due to these symptoms. So we think these NPI severity, the symptoms should really be the focus of intervention strategies. But one point I want to know is, like, when we control for resources, this kind of partially mediates that effect. So it was close to significant, and it just barely reduces it. But resources were not significant to caregiver turnover, which I think is surprising, because we thought they would be help enable the caregiver to remain, in the caregiving role over time. And the second table, we're looking at depressive symptoms here. So quite a little bit of a different story than what we found for caregiver turnover. So longitudinally, we find that only Spanish language interview was a significant predictor for change in depressive symptoms. So with caregivers who completed the interview in Spanish reporting a greater increase in depressive symptoms across waves. In our previous research, we've also looked at caregivers who've completed the interview in Spanish. We've also looked at caregivers who provide care to an older adult that was born in Mexico. And we find that there's differences in caregiving networks, especially smaller caregiving networks. And so we are thinking maybe this kind of impacts these changes that we see, this increase in depressive symptoms over time for this group. And so in our second model, we include perceived stress. Surprisingly, NPI severity wasn't associated, which we usually find with cross-sectional studies. So I think this was an interesting find. But we find that actually, this is a very strange finding, that caregivers with high level of higher stress report a decrease in depressive symptoms between waves. And so we think this is maybe looking at, like, we don't look at change in stress, so we really need to look at change in stress between the waves to look at how this relates to depressive symptoms change. So it might be that just people with low perceived stress have somewhere to go, right? So have somewhere to increase over time. And this is really why we have this kind of more strange finding. And then for caregiver resources, we have help outside of the family was a significant predictor. And this is also, and also people who receive help of the family from outside the family report an increase in depressive symptoms from baseline to follow up. And this is often seen, so in our qualitative research, we also looked at this, is seen kind of as the last stop, right, before caregivers experience a lot of burnout and stress. And so it's like, if I don't receive help from outside the family, it's kind of a last effort in terms of the caregiving situation and supports. And so that's why we think there might be this increase over time. But here's just breaking it down just to kind of look at the bivariate relationship, because sometimes I think that helps to kind of elucidate what's going on. So here for Spanish interview, here's the depressive symptom scores at wave 1 and then at wave 2 in dark blue here. And so we see that the caregivers who completed this the interview in English have reported decrease over time in depressive symptoms, where the caregivers who completed the interview in Spanish report this really elevated increase right between the waves. So we really need to understand, what are some other potential mediators that are causing this really rapid increase in stress for caregivers who completed the interview in Spanish. And similar with the low perceived stress. So here we can see actually for the English interview respondents, there was a decrease, about a majority more in the low perceived stress group, but even more were in the low perceived stress group with the Spanish interview. And this perceived stress was only at baseline, only available at base time. So our next steps are really to identify some other potential mediators explaining this relationship. So in conclusion, so some factors associated with caregiver turnover, I talked about this briefly, may reflect expectations and the current timing of social roles. So really, what our results show is that strategies that, because the MPI symptoms address dementia education, caregiver safety, and that increase screening for NPI symptoms is really important for prevention and intervention approaches. Also, our research is showing that dementia care outreach is really important, and we need to look at the unique support needs of Spanish-speaking Mexican-American caregivers to really understand what we can do to reduce strain and reduce stress associated with the caregiving role. Thank you so much. That's it. Questions? Or maybe, are we going to do questions and comments at the end?
We will do that, take all questions at the end. So please jot those down, and we'll be adding those to chat. Feel free to do that as we speak. We're also going to just make some technical adjustments here in terms of the camera position for Dr. López-Ortega. So while we are waiting for that, and Carolina's guidance, we'll just pause for just a moment, because our next presentation will be entitled Pathways of Care, the Experience and Costs of Caring for Family Members Living with Dementia in Mexico. This is a very important component of our project, comparing living arrangements and dementia trajectories in Mexico and the United States, particularly among, of course, our Mexican Americans, and understanding how both nations are similar, as well as how they approach the caregiving task differently, is what we're trying to learn today through all of the papers that we are writing. Dr. López-Ortega is from the National Institute of Geriatrics in Mexico, and she is a senior research investigator, and she's been part of the team here, binational team in the United States for many, many years now. And we are so delighted to have her with us here today from afar, actually. Correct, Dr. López-Ortega? Here.
Sorry. Hi, everyone. Thank you, Jackie, and thanks for the organizers for accepting this panel and the opportunity to present. I'm going to share the screen now. I hope it's, I'll put it in. So is it okay now? And I know we should have the video on, but my connection is not very stable, so I don't know if, or you know, if it gets complicated, I will turn it off, but I'll try to sort of have it on. So as Dr. Angel was saying, I'm gonna present a part of a study. Well, the presentation that I have today is called Pathways of Care, the experience and costs of caring for the people with dementia in Mexico. And sort of the study aims are first to understand the costs of providing unpaid care work for family members with dementia in Mexico, and to understand the associated economic, social, and health, I don't know why it's moving, understand the associated economic, social, and health consequences of this unpaid care. So this is part of a larger or a wider project. It's part of the Strengthening Responses to Dementia in Developing Countries project. The main objective of the large project is contribute to improving care and systems so that people living with dementia can live well, and that their families and other caregivers do not assume excessive costs, do not risk falling into poverty, or compromise their own health. This was a 4 years study that lasted 4 years. It just finished in March in terms of the formal project, but we're still doing a lot of the analysis and reports and writing up articles. It includes 7 middle-income countries, among them Mexico. It is funded by the Research Council in the UK and the Central Management at the London School of Economics and Political Science. And it's in every country, it's a multinational and multidisciplinary team of researchers, and in every country supported by the collaboration with civil society, whether at the macro level by the Alzheimer's Disease International Association and different international organizations. And it's constituted by 8 working packages. And in Mexico, every country has the cooperation, the research institution, and a civil society organization. And in Mexico, the project is carried out at the National Institute of Geriatrics. I'm the principal investigator, together with the Mexican Alzheimer's Federation and its affiliated associations, around 19. And of course, one of the main objectives is to use the evidence generated to formulate or have policy recommendations. So what I'm going to present now is just the preliminary results, because it's still work in progress, of one of the working packages, which is dedicated to unpaid care and its consequences, as I mentioned. So the work, the method, the field work for this part of the study included in-depth interviews with people who care or have cared for a family member with dementia. When we started the project, we were doing in-person interviews, but of course COVID came and we had to stop in-person interviews. And after a while, when we saw this was not changing, then we started doing remote interviews, either by phone or video calls, depending on the preference of the participants. So we have 50 interviews with 23 participants, and with most of them we have at least two interviews, but with some of them we have 7 interviews. So it's like a wide range, but with all of them we have at least 2, or most of them we have at least 2. So we did these interviews in 3 localities, 2 urban, large cities, Mexico City and Toluca, and 1 semi-urban in the state of Chiapas. And of course, COVID, as I was mentioning, brought in many challenges. But I mean, in a way, one good thing, and of course I'm sort of quoting, is that in moving to remote interviews, it allowed us to have to contact, for example, associations in other Alzheimer's associations in other states. And we were able to get interviews from the state of Chiapas, which is in the southern border, and it has a very different setting and economic and everything than the other 2 large urban areas that we were doing in-person interviews. So some challenges, but some other very good opportunities to have much different information. And as I was saying, we have multiple interviews with each participant, and this has allowed us to have a wide range of topics and depth of the discussion and conversations that we had with the carers. And some preliminary results, and I want to talk at 2 levels. First, just briefly at the personal level, or what we're calling now a personal level, I want to present 2 emerging concepts. First, that of feeling trapped. That the beginning of intensive care provision for someone with dementia is an event that divides one's life narrative into a before and an after. And after signals sort of the end of freedom to direct one's own life, and that there would be no meaningful breaks in caregiving. There's like no way out. Caregiving responsibility is relentless. And for example, participant 9 talks about the constant care for her father, and how when her father is at daycare, she's doing so many other things like cleaning or washing the clothes, getting things ready for him, how her siblings don't provide care because her father doesn't want to, she just wants her. So it's feeling that, I mean, even if I wanted, do I have wanted to? Do I have a choice to not do this? And for example, participant 19 talks about being in a cycle of giving her mother, dinner, getting her in bed, going to see her 2-3 times at night because she gets up. In the morning, it's again starting this cycle, breakfast, lunch, do housework, and sort of a cycle that never stops. And so we have here a quote that can shows a bit of this concept of feeling trapped. Participant 19 again tells us it is very difficult to accept that this is your life. I mean, that everything spins around this, around Alzheimer's, and that even if you have lots of money and you have enough to pay someone to take care of her for you and everything, you're always going to be in charge of her, right? It's accepting that your social life has ended, your life, your tranquility. If you don't get on with your spouse, you say, no, that's not my life. I don't want to live this way. So you separate. But here, there's no way to separate myself. I have to go on here. There is nowhere to go. Another interesting concept that has come in many interviews is that of restructured lives. So being the main carer of a family member with dementia transforms lives and plans which have to be changed and restructured. There are no alternatives, or for now, probably no preferred alternatives. And so changes have to be made, even if they bring high opportunity costs and have negative social and economic impacts, as well as an impact on their health and well-being. So, for example, one participant lives in Mexico City, is divorced, and lives with his teenage son, and her mom lives with his sister in another state. But not being able to find specialist care, they decide that for his mother to move in with him, and not only that, in terms of changing living arrangements, but he has to leave his position at a company for another one that is less challenging, significantly lower paid, but he gives him the flexibility to be in charge of his mother. And another participant 18, lives with her mother, and until recently, when we did the interviews, had a full-time job and a business, a restaurant bar, but due to her caregiving responsibilities, she had to quit her full job. Now had only the bar, the business, the restaurant bar, but of course, due to COVID-19, it had been closed. So imagine sort of like the economic impact of like you don't have your job, and then you have to sort of close the other business. So in terms of the economic or the income that you need to sort of take care, it's very challenging. Also. And I mentioned this a little bit, sort of an important number of participants that had to restructure their life, either because they have to change their job, or they have to move to another city. But we also see very important personal habits transform that can potentially have a harmful effect on participants' health and well-being. Just an example, for example, how much participants sleep. If they manage full nights of sleep, even if they go to sleep, they are always sort of on the back thinking, or they have to wake up several times at night, or if they used some time previously to exercise and do other things that now they cannot do. And then at another sort of structural level, sort of what so far things that we have identified in different, in several interviews with several participants, that these are long care trajectories, and most of the people, by the time they have a diagnosis, or a sort of even not, probably not an MRI, but a very good diagnosis, it's very late on. So, but even so, they are very long trajectories of care, 10 or more years, with little or no accompaniment from the health, social security sector. And there's a large lack of knowledge, a lot of normalization of cognitive decline as part of aging, and a lot of stigma, like not externalizing, like trying to sort of, nothing is happening, or this is normal, I should not talk about this. So this delays care seeking a lot. So very few things can be done, or in terms of trying to manage, it's really when symptoms are very profound or intense. but also when there is a diagnosis, there's little or no explanation by health professionals about possible change behaviors, what to expect. So family members are really left with sort of having to seek attention elsewhere. For example, there's a lot of self-learning strategies, such as support groups, the internet, information from other associations, even from other countries that are Spanish speaking, that probably do have this information available. And on another sense, of course, I have talked about this high economic impact to family members, and not only because they have to sort of stop working or change their jobs, but they have to spend on material, a lot of things to support the care, and we need to give this a value. For example, some caregivers mentioned that previous to COVID, the pandemic, they were able to take there are a few day centers for people living with dementia, but those that have this service now they refer to as the COVID pandemic have a very high negative impact because there were no moments of respite. So I had like at least 4 or 5 hours a day when I could do other things or tend to my home, and now I can't. So that also has a very large impact. Changes in home arrangements, as I was saying during the life course, either families migrating or to have a diagnosis or just to be able to care for the person. And for many, it's very interesting, but of course, very alarming in a way for many participants. After 8, 9 years or 6 years, 5 years, they say, you get this expression, as they were saying, in retrospect, there were a lot of things we could have done. Like if I had known I could do this, I could go there, things would have been really different. So this talks about a lot, if we create strategies to have more knowledge, more support, at least more information, there's a lot of things that can be done. So as I was saying, this is just some, it's still work in process, but I think we already can identify a lot of things that are really important. So just to finish, some acknowledges of course, the funding agency of the Whole Stride project, the UK Research and Innovations Global Challenges, to all the participants who agreed to be part of the study because, they have shared so much information that is of great value. Our fieldwork team, the interviews that helped me with the interviews, of course, the translators, because as I'm doing, this is an international project and some of the principal investigators are in the UK, so everything has to be transcribed, translated, and then analyzed. So it's a huge process for one interview that we have to go through. And of course, we have a national advisory group of relevant stakeholders and for the project since the beginning. And of course, to all the Stride Dementia Project, because, the collaboration and all the exchanges we have done through the years has been amazing. That's just some details, and that's it. Thank you very much.
Thank you very much, Dr. López-Ortega.
Okay, they asked me to be silent for a few moments while they adjust the camera, but they tell me to turn my camera off. 1 second. Turn on your cameras. Okay. Okay. Well, I'm going to go ahead and get started because we're getting down to the end here. I'm Phil CANTU. I'm a postdoc at the University of Texas Medical Branch. I'm presenting some work that I've been doing with people here on this panel. Dr. Mariana López-Ortega, Dr. Ro, Jackie, and graduate student Jiwon Kim, looking at changes in living arrangements and dementia in the United States and Mexico. So you got a lot of context on older adults with cognitive impairment and dementia. Just a little bit more. We're going to discuss about the context of the living arrangements. We're going to document living arrangements for older adults in U.S. and Mexico, and we're going to describe how the differences in living arrangements interact with cognitive impairment dementia by gender. So for a cross-national comparison, it's important to note that among Mexican Americans, there's really low nursing home use compared to non-Hispanic whites and other racial and ethnic groups. Instead, family members tend to live, or older adults tend to live with family members even when they have a dementia diagnosis. And when they do go into nursing homes, it typically is further along a dementia diagnosis, meaning that they've had dementia for a longer period of time before entering nursing homes. By comparison, in Mexico, there aren't as many aging policies, and there's a lack of a federally regulated long-term care systems comparable to the United States. And part of the reason for that is that demographically speaking, Mexico has undergone a much more rapid demographic transition. They've grown old much more quickly than the United States has, and their systems aren't necessarily able to develop along the same time frame as the United States. And I think it's also important to note that when we talk about cognitive impairment and dementia in Mexico and the United States, we're talking about two populations that exhibit particularly high levels of dementia compared to non-Hispanic whites in other nations. For living arrangements, in the U.S., living alone is not that uncommon. 28% of older adults over age 65 live alone, while only 11% of Mexicans in Mexico over age 60 live alone. And one of the reasons why how living arrangements are important is that spouses and household extension represent important sources of care for older adults with dementia, and particularly older adults with dementia have particularly high levels of need. Dementia represents this continuous demand for care and instrumental support. So I'm showing here living arrangements in Mexico along the life course by men and women. And what I really want to point out is on these blue bars are people are living with others, having extended household, and the gray bars are living alone. And as you move up in the life course, more people live alone. And so we want to get a handle on what does it mean for more people to live alone in late life when there's a higher prevalence of cognitive impairment in late life. So in this paper, we document the changes in living arrangements across the life course for Mexicans and Mexican Americans. And we want to see if there are any differences in the patterns of living arrangements for Mexican Americans by gender. So we have a couple of research hypotheses that guide this analysis. First, we think that older adults with cognitive impairment with dementia who live alone are more likely to move in with others than people who don't have cognitive impairment or dementia. So there's a health imperative on extending the household, on moving from living alone to living with others. And additionally, we take into account the competing risk of mortality, and we anticipate that living alone is a risk factor for mortality for older adults living with cognitive impairment and dementia. So in order to do this analysis, we use two data sets, one in the United States, the Hispanic EPIs that Dr. ROTE talked to you a bit, and one in Mexico called Mexican Health and Aging Study, the MHAS. We look at this data longitudinally for the years 2012, 2015, and 2018. Our dependent variables are living arrangement transitions, so going from either living alone, living with others, or living with a spouse to any of the other living arrangements, or to death. And we do this using multinomial logistic regression, looking at living arrangement origin. We control for some key independent variables, age to get a sense of the life course, gender and sex, because we know that men and women have very different life courses, education as it's a risk factor for cognitive impairment and dementia, the number of living children somebody has as a proxy for potential people to have in an extended household. We control for dementia status as measured by MMSE, the mini mental status examination, and disability in the Mexican survey, or in the Hispanic EPIs, and in the Mexican Health and Aging Study. We use something called the cross-cultural examination or cognitive examination in IADL disability. And then for finances, we look at poverty. In Mexico, we use the bottom 40th percentile of wealth as a proxy for poverty. And in the United States, we use Medicaid eligibility or Medicaid enrollment as a proxy for poverty. And so just so you can see, we're talking about a fairly old population with low levels of education, but they have high numbers of children. The majority of the sample in both samples were women. There were high levels of poverty in both samples, and dementia prevalence appeared to be higher in the Hispanic EPIs than in the MHOS, but that is partially as a result of the different measuring stick, the different tool that we've used for looking at dementia in these two different populations. Using a different measurement, we have found more comparable levels of dementia in the past. Here is our deepened variable, the transitions in living arrangement. And I just want to point out that the diagonals, the staying in the same living arrangement between waves, was the modal category for both the MHOS and the Hispanic EPIs. People tended to stay in the same type of living arrangement they were in. There's a lot of stability in living arrangements in late life. And when we looked at our multinomial logistic regression, we found pretty comparable results between the MHOS and the Hispanic EPIs. The results were remarkably similar, really similar size coefficients on predicting transitions, with an important exception that dementia and cognitive impairment were predictors of transitions in living arrangements from living alone to living with others in the Hispanic EPIs, but it wasn't in the MHOS. One of the reasons why that is we hypothesize it has a lot to do with the selection process and the distribution of living arrangements. So most people in late life live in extended households in Mexico. It's rarer in the Hispanic EPIs in the United States. So when we look at the actual transition probabilities, we don't necessarily find evidence for this hypothesis that changes in cognitive status were leading to changes in living arrangement. So you can see on the left-hand side, we have results from the MHOS. On the right-hand side, we have results from the Hispanic EPIs. These are transition probabilities. And what you see on the left side is that women in the MHOS had slightly increasing probability of transitioning to living with others from living alone. But most people who were living alone were not transitioning to living with others, while in the Hispanic EPIs, there was a larger proportion of women who were transitioning over to living alone. We think this has, again, to do with the selection into living alone happening earlier in the life course, and living alone and living arrangements being stickier, being more consistent in the MHOS compared to in the Hispanic EPIs. So when we look at transition probabilities from dementia, by age and dementia from alone to death, we see that men who live alone, and especially older men with dementia, had an increased risk of mortality with age, while the risk of mortality among older adults living alone in the Hispanic EPIs was pretty flat across all ages. And again, we think this is possible because the selection process is different in the US than in Mexico. Older adults in the US who live alone are the most robust, while those who live alone in Mexico have the least support or in the most precarious situation. So conversely, while we see living alone being this sort of protective factor and in the US and a risk factor in Mexico, older adults who live with others in the United States see elevated risk of mortality, mostly for those with dementia, while older adults who live with others in Mexico have a relatively flat mortality risk. So older adults who live with others in the US are doing so because they're the worst off, they're the least healthy, and have the greatest need, while living in extended households in Mexico is the norm. So the conclusions that we come to were that living arrangements in Mexico were more stable in Mexico compared to the United States, where they're more dynamic. There's a relative stability in the living arrangement in Mexico, suggests the importance of the selection process earlier in life. So it's an early life course phenomenon that sorts people into the different living arrangements, and that selection process really varies in the two nations. So living alone in the United States is likely a marker of being able to be independent and being healthier, and living with others is a marker of being less healthy and then needing more support. While in Mexico, the opposite is true. Living alone is a signifier of having a smaller support network and not being able to get support that's needed. And lastly, I think it's important to note that there are more options for different types of living arrangements in the US compared to Mexico. And one of the things that we struggled with in this analysis is we haven't really done a great job of breaking out individuals who are living in assisted living facilities who say they are living alone, but they're actually having full-time support in the US population. So one of the things that Mariana talked about in terms of living arrangements were the types of extended households. So somebody may actually be changing living arrangements in Mexico, but the composition of their household has changed drastically. So it may look like they're just living in an extended household, but they may have had to move in with a different type of family member or in a different type of living arrangement. So we would like to push on that bit of data in the future. And we want to get into the dynamics of marital status because women are more likely to experience widowhood. Men die earlier on. The type of precarity that women experience are different than the types of precarity that men experience. And we'd like to get a handle on how that interacts with women's higher rates of cognitive impairment in late life. So thank you so much. This work was supported by the Texas RICMAR, a T32 training grant, and the Hispanic EPIs and MHAS itself. Great. Mariana, I wanted to ask you about your role in the project. Are you able to actually take part in any of the interviews, or are you strictly in like the data analysis side of it? Yeah, Mariana, you're muted.
Sorry. No, Phil, thanks for the question. Actually, I'm the principal investigator in Mexico for the whole project, but as different to other countries, I mean, each country had their own sort of arrangements, and I was one of the few that not only was like I sort of doing the managerial organizational stuff, but I was very hands-on on all the working packages. So I was together with one of the researchers here in the UK doing all the methodology, and I was able to do some of these interviews. So it was the 3 research assistants plus myself doing the interviews, and they well, I didn't do any transcribing, but they did the transcribing, and then they were all sent to translate, and now we're doing the analysis. So I have been involved in everything, in the whole process.
That's really fascinating. So I want to ask you a little bit about your hands-on experience as it relates to living arrangements. Did you get much of a sense of were people having to change their houses to accommodate having somebody live with them, or were people moving to different houses to live with somebody, or what were the directions of the sort of changing in living arrangements?
So I think, for example, in the interviews so as I said, it's 23 participants. I think for those that have moved or have changed their living arrangements, most of the time it's been the person moving, like the person living with dementia, moving with the carer, either a daughter, a son, etc. But at least in our, in the persons that we interviewed.
Yeah, I mean, that's really, it's fascinating because in the Hispanic EPIs and some of the living arrangements research we've done, what we found is there are really, sort of 2 flavors of caregiving. There are children who are less established, who are unmarried, who don't have their own children, who may have lower incomes, moving in with the older person who they're caring for. And conversely, there's more established children. So people who have their own children, their own family, maybe a well-paying job, having the older adult move in with them. And so to hear that, that second one is more the norm in Mexico is interesting.
But probably it also relates, Phil, to the kind of sort of, I mean, we did an open sort of invitation, right? So, and then we got the people from different places sort of, calling in to see if they could participate in the project. And I would say that most of them are the ones you referred to sort of like later on, sort of most of them are 50 or plus. and most of them have their own children, or even they were never married. They're also in another sort of, they have work. They are in that sort of later age. I don't know, like adult, not that young. So then that's why probably, as you say, they were more established, and then they can afford to have the person in terms of because of their living arrangements or the economics of having them move with them.
So it looks like we only have time for maybe one more question. So if nobody else has a question, I'd like to ask Sunshine a little bit about her research. Sunshine, so one of the things that you hit on was that 68% of the caregivers in your sample gave the interview in Spanish. My understanding is that's actually much lower than the percentage of the respondents who do the interview in Spanish. And I wonder if you could say a little bit about that, about the differences between something like 95% of the respondents speaking Spanish as their primary language and almost 70% of caregivers.
Yeah, I think that's a really good question. I think in the older adult sample, we have quite a few older adults born in Mexico, as you show, as we've seen in the data. And so, I think that accounts for some of it, where most of the caregivers, it looks like, were born in the United States or born in Mexico at a really young age. Right. And so there's that difference there. I also wonder about, I really haven't asked Kokos, who is the PI on the project, about this, but also, so when they're doing these interviews, I mean, the older adult could be in the same room as the family caregiver, and I don't know if that impacts which also language they choose in terms of the interview, because if you think about it, if you're sharing a house and you can hear everything going on, and the interviewee or interviewer is asking all these questions, then the viewee, the caregiver might, that might also impact which language they take the interview in too. So I think it's definitely something to unpack and to explore in more detail, why less caregivers are completing the interview in Spanish versus older adults.
Excellent. Thank you all for your outstanding presentations. These projects have much to develop. They've already are contributing so much with respect to what we need to understand in terms of looking at low resource nations and low resource environments. And I think that's one of the sort of underlying themes that comes across all three papers, and the fact that there's a lot of diversity in the caregiver network. And clearly there needs to be a lot more research along those lines, and also our cross comparison and cross-national work to really understand some of these nuances. I think the STRIDE data really do outline that, and those two sort of theoretical perspectives, we'll be excited to hear more about that, along with the Hispanic EPIs and the Mexican Health and Aging Studies data, which will give us another set of points to be able to look at how this is changing over time, the trajectory of dementia and living arrangements simultaneously. So I did want to give everyone just, if we have just one more moment, last chance to share with us any reflections about the other papers. Thank you, Phil. Sunshine?
I feel like I really love Mariana's presentation of the qualitative research. I think it really shows like similar kind of findings across different caregiver samples. So I just thought it was really illustrative and really, really nice. And then Phil's, I thought, is super dynamic to compare across time and across space. So yeah. You're muted, Jackie.
Dr. López-Ortega, would you like to share anything else regarding the presentations?
Well, just that I'm very excited to be part of this group and to our continued collaborations. I think that both quantitative data and qualitative data make a very good complement, and we should sort of continue to explore those and complement that work. And sort of great presentations for Sunshine and Phil. Thank you.
And we'll continue to collaborate. We have a dynamic team. We have dynamic data, but also a dynamic team, and clearly including both narrative as well as numbers in all of our analyses is an important aspect of what motivates our discovery on this area, because it is so dynamic and intricate, which is also what we're showing as well. So if there is nothing else at this point, I want to just remind everybody that there are 90 days that these presentations will be available to everyone. And if you would like to drop your email address in the chat, you're welcome to do so. I know that most of your emails were available on your slides, however. And with all that, thank you so much. Enjoy the rest of the meeting, and we will see you at the next Congress.
Yeah, I just wanted to say one more thing. If you're interested at all in learning more about the Hispanic APPEs or doing research on Mexican Americans in the Southwestern United States, feel free to reach out to me at phcantu@utmb.edu. We're always looking to add new collaborators and start new projects. So I hope you enjoyed these presentations. Thanks to everybody for being a part of this panel, and thank you for listening if you're here. Everybody have a nice day. Thank you.
Thank you.